Welcome back to the COVID Sense series. Today we'll be looking at vaccines, and we have Deanna McLeod here to walk us through the data. This is a 4-part video series on vaccines. In the last video, we looked at mode of action and development, and today we'll tackle the topic of efficacy. So Deanna, what do we need to know?
Well, there's a lot of good questions that we need to ask when we're looking at this vaccine data. Basically, the first and foremost, is it effective at preventing a COVID-19 infection? Can it prevent serious illness and death? Can it alleviate some of the burden on our healthcare system? And can it prevent the spread of COVID-19? So those are all the big questions, at least that I have on my mind when we want to look at the data. So let's just jump in. Here we have the phase 1-2 trials for both the biotech vaccine and the Moderna vaccine. And these plots look totally complicated, but don't worry about that. They're actually pretty easy to understand. So over here on the biotech side, we basically are looking at antibody titers for 3 doses, a 10 milligram dose, a 30 milligram, and a 100 microgram dose. So those are the different colored columns right here. The study looked at safety of the vaccine, but it also wanted to look at antibody production. So here you've got the antibody levels charted here. And so what we can see is after the first dose of the vaccine, there weren't a lot of antibody levels. We waited a week, we waited another week, and after the second dose, we started to see more antibodies produced. A couple weeks after that second dose, we've got our full number of antibodies here. And the level of antibodies produced here was similar to the antibodies produced in something they called convalescent plasma, which is basically the blood of somebody who's been previously exposed to COVID. So one COVID-19 exposure produces this level of antibodies, and the vaccine produces this level of antibodies. So basically what we're looking at least in healthy adults, is similar levels of antibody production. So they basically considered the vaccine to be successful in producing antibodies. We jump over here and we look at the Moderna data. Again, not a lot of antibodies produced with the first dose. After a second dose, in a little bit of time, we've got a good level of antibody production, which is comparable to convalescent plasma. So the antibodies of somebody who's been previously exposed to COVID-19. Yeah, there was some concern that maybe COVID-19 antibodies were transient, but I think that was mostly pointing to the fact that we just didn't have a lot of data on how durable it was. COVID-19 was a new infection. People were just recovering from it, so we really weren't sure how durable the immunity would be. And so what we do know now is that there's 7 months of data on COVID-19 antibodies. And right now, what we can say for sure is that the vaccine can induce spike antibodies, but we're really not sure how durable those antibodies are because, again, we just don't have data over time. So this particular trial was, I think, had a 2-week follow-up. So we know that we have weeks of durability data for spike, but we do at this point have a good number of months of data on durability of COVID-19 antibodies. So whether you've developed your antibodies through a vaccine or through natural exposure, we know that people are able to develop immunity to COVID-19. So why don't we look at the phase 3 trials now? The phase 3 trials are really important because phase 3 trials are the only ones that can actually help us determine whether something can cause something. So we want to look at whether this vaccine can cause a reduction in the number of COVID-19 events in those who take them. So we're looking at 2 New England Journal of Medicine publications, so the biotech one and the Moderna one. And here we're looking at the schematic of the trial. And this might seem foreign to a lot of you. This is something that we always look at when we're analyzing data, is how the study was designed, because if you understand the design, then you can understand the type of questions that it's powered to answer. So here, the first thing that we want to consider is who was enrolled into the trial. So that's what this little box looks at. And here we can see that there were healthy adults enrolled into this trial who were older than 16 years. They had no known history of COVID-19, healthy immune systems. Some of them were at risk of maybe severe disease or increased exposure, like they were health frontline workers. But for the most part, these people were healthy. Both trials randomized patients to one of 2 arms, a vaccine arm or a placebo arm. which is fantastic because that reduces the placebo effect or the potential bias that might be introduced by people who want the vaccine to work. Again, they've got the 2 doses. The first dose, waiting 2 to 3 weeks. A second dose, wait 1 to 2 weeks. And of course, we know by looking at the phase 1 trials that was because we want to make sure that they've got full antibody titers. And then at that point, what they do is they start to look for patients who have COVID-like symptoms and a positive PCR test. And that's their primary endpoint. So what they're really designed to look at is, can we reduce the number of people with confirmed COVID-19? The biotech study was also designed to look at systemic events, so adverse events that might occur. So, is it lowering the COVID-like symptoms that are associated with the disease? And both trials had really good numbers. We're looking at 43,000 in one trial and 36,000 in the other. So overall, the design is great. The numbers are solid. As per expected, we're looking at in healthy adults. But what this study does not help us answer is the efficacy or safety in vulnerable populations, because only healthy adults were enrolled into the trial. The second thing it doesn't do is it doesn't give us, at least this particular data set doesn't give us, and the design of the trial didn't support a consideration of severity of disease, the use of medical resources, or death. So we're not going to be able to conclude anything about those things from this data. And it was not designed to assess whether it prevents the spread of the disease. So that means that if you did take the vaccine and you got a COVID-19, you were infected by COVID-19 and your antibodies were able to clear it, are you infectious at any point in the time when you're clearing that COVID-19 infection? And that would be your degree of contagion. So again, another thing to consider when looking at this phase 3 trial is that it was an interim analysis. It means it was an early peek at the data. The trial is not finished, and it's really looking at only 4 months of data. So that's not a lot of time. Usually these trials go on for 1 to 2, maybe even 3 years before we would be able to conclude anything about the data. So again, given our circumstances, we're in an emergency situation. We're looking at an interim analysis of the data, so an early sneak peek. So basically, what did we see? Let's take a look at the results and find out what it looks like. So here we have both trials plotted in a single plot. The plot here is the proportion of people who experienced a positive COVID-19, who had a positive COVID-19 case. So this is the biotech data on the left and the Moderna data on the right. The first column here in blue is the placebo arm, and 162 people in that arm had a positive COVID test. Here we are looking at the vaccine arm, and only 8 people had a positive COVID test. Again, we see the same big difference between the 2 columns with 185 and 11 on this side. And so basically what that means is the relative risk reduction, the difference between this point and this point, is about 95%, and that's where they get their 95% efficacy. For the Moderna trial, it was 94% relative risk reduction. So that's looking very good. It's showing us that people who are in the vaccine arm actually have fewer positive COVID tests than people in the placebo arm. Again, we're looking at really good numbers here. But a couple things that we want to consider when we're looking at this data, even though it does look very promising, is that the absolute benefit, which is basically the number of people who benefit after receiving the vaccine, is actually quite low. It's less than 1.5%. So of the 100% of people who received the vaccine, only 1.5% of them are actually going to benefit in a reduction of COVID-like symptoms. And that's because the event rate is so low, which may in part be due to the fact that COVID-19 is not prevalent right now, or it's the short follow-up. So the other thing we want to be looking at is those people who were lost to follow-up during that time period, during that 4-month time period. So here, what we see in the placebo arm is 316 people were lost to follow-up, 304 people on this arm, 531 and 416. And when your lost to follow-up rate supersedes or is higher than your event rate, what that does is it suggests that there could be a level of uncertainty in the data or the reliability of that effect, because people who may have dropped out may have been more or less on one or the two arms. So for me at this time, when I look at that, I think, could it be that the effect that we're seeing is really just people randomly quitting the trial rather than the vaccine actually reducing disease? So that's something that we want to keep our eye on. And again, when we think about the absolute benefit, what that means is if we wanted to, if we vaccinated all of Ontario, which is 10 million people, we'd be able to reduce the cases by 123,000 based on this data. So again, not a big effect for a very large undertaking of giving all of Ontario 2 doses of a vaccine. So another thing that we want to look at again is cases of at-risk patients and cases in elderly patients. These are our vulnerable populations. So again, we really enrolled healthy adults into this trial. So even though they were at risk, they were actually healthy. Same thing with the elderly patients. So although this is insightful, it really doesn't tell us how a person who has a number of comorbidities and who isn't healthy would tolerate the vaccine or respond to the vaccine. But anyways, regardless, let's look at what our data. So we've got our placebo, we've got our biotech data on the left, we've got our Moderna data on the right. We're looking at risk patients. The first thing that we want to be thinking about is how many patients are included in this subgroup. So we see that in the biotech data, 16,000 at-risk participants were included. In the Moderna trial, basically it's 6,000. So I would say that this is probably fairly robust in terms of a number for the biotech data, but a little bit slim for the Moderna. And here we do see that that big difference in relative risk reduction here and relative risk reduction here, which is fantastic. But again, now our absolute benefit is much lower. We're looking at basically 0.5% of people benefiting from this difference in this trial. When we look at our elderly population, one of the things that we want to look at right away is the number of people who are included in this subgroup analysis, and we see really that there's only about 1,500. That number is not high. It's certainly not sufficient to extrapolate the data from this particular trial to the general population of elderly patients, especially those who might not be in the best of health. And again, for the Moderna data, we have 7,000, again, a little bit on the low side. So overall, I would say that we probably don't have enough patients in this particular cohort to be able to extrapolate to elderly people in general. Although we do see a good relative risk reduction here between the placebo and the vaccine. Again, we need to consider these relative risk reductions in the context of the people who were lost to follow-up and the uncertainty that introduces into those values or into that benefit. And the other thing that we need to consider is that we're going to have to vaccinate a whole heck of a lot of elderly patients in order to reduce the number of cases in a select few. So those are the efficacy data. It looks promising, but because we were looking at an early analysis and an interim result, I would basically want to see more follow-up, and I would like to see randomized controlled trials in our populations of interest, which are our at-risk patients, including patients who might not be healthy, and our elderly populations, before I would go ahead and make any strong conclusions about the benefit of the vaccine in those particular populations. So we talked about the fact that that we're looking at an interim analysis, and that means that they basically kind of stop the trial, take a look at things kind of as it's going on. And one of the things that they did whenever they wanted to submit to the FDA is they produced a much more robust data set for their review. And I'm looking at the FDA briefing document here, and on page 42, they actually look at something called suspected but not confirmed COVID-19 cases. So these are people who the clinicians saw looked like they had COVID-19, but they hadn't actually got a confirmation on their PCR test yet. And so basically the numbers there are considerably higher. So again, we were looking at about 150 COVID-19 positive cases. But when we look at suspected cases, we see that the numbers are quite a lot higher, like 1,500 here and 1,800 here, which makes more sense considering we were looking at about 30,000 participants in the trial. If we were to consider what that looks like if we included it, or we used an analysis where we were looking at confirmed, or when we looked at confirmed and suspected cases. So here was our original analysis. So we've got our difference between placebo and the vaccine and our 95% relative risk reduction here. If we included suspected cases in our analysis, what you would see is that the placebo arm, again, is higher than the vaccine arm, but the relative risk reduction is much lower. So what we're really wanting to see, or what we really need to see, is some further follow-up to find out if these suspected cases actually do become confirmed, and if that's the case, whether this large differential that we're seeing here remains after we get those positive PCR tests. So the thing that I would basically emphasize looking at this slide is that at the present time, we really need to suspend our conclusions around the efficacy of the vaccine until we have our completed trial results, which are published and available for public scrutiny. So that basically confirms all, or that based on this, we basically reviewed all of our data for the cases of COVID, or confirmed cases of COVID, which was our primary analysis. But we also had questions about whether it was able to reduce disease burden or COVID-like symptoms. So although the trial's primary endpoint didn't look at that, what we were able to do by looking at something called unsolicited systemic adverse events reporting, what this means is that every trial has to report everything untoward that happens to participants on both arms of the trial. And so they've got very detailed reports of systemic adverse events that occurred. The unsolicited means that they were basically on-script or off-script adverse events, or things or symptoms that occurred, whether it was something that they were looking for in the trial or they weren't looking for the trial. And that's really important because it gives us the full sense of the experience of people or participants on the trial. And when we look at this data, there's a few things that we notice. So again, we've got our biotech data on the left-hand side. We've got 108 on the left-hand side here. We've got our Moderna data on the right. We've got our placebo column and our vaccine column. But one of the things that we notice right away, and this is basically after about at least one dose of the biotech vaccine or placebo, is that instead of having a reduction in adverse effects in the vaccine arm, we have a dramatic increase, a relative increase, risk of increased chance of getting COVID-19 in the vaccine arm. Over here, when we're looking at the placebo, on the Moderna data, we have about a 50% level of risk of having a COVID-19 symptom with exposure to COVID-19 here. And then on the right-hand side, in the patients who didn't have COVID-19 or had a lower level of COVID-19, you've got 150% relative increase in the risk of getting COVID-like symptoms with the vaccine. So this is probably the opposite of what we were expecting. We were expecting ideally that the vaccine would be able to reduce disease burden or COVID-19 symptoms. And in fact, what we're seeing is that there's dramatic increases in the relative risk of getting COVID-19 symptoms, especially with 2 doses of the vaccine. Now, again, as we looked at with the previous figures, we want to know how reliable these results are. So what we want to do is compare the number of events to the number of patients lost to follow-up. And you can see here that our events are much higher than the events, 300 to 500 people who were lost to follow-up in each arm. So we definitely know that this vaccine effect is reliable. So again, if we consider the number of patients affected by this vaccine, so 90% of people who would be receiving the vaccine would experience an adverse event, which means that if we vaccinated all of Ontario, basically we would cause COVID-like symptoms in about, if we did 2 doses, which is the Moderna data, about 4,148,000 people. One thing that we can conclude is that the phase 1 studies did show that the vaccine after 2 doses is able to stimulate antibody levels similar to one exposure to COVID-19. We know that this early interim analysis of the trial basically suggests that there may be a relative risk reduction in COVID-19 cases with the vaccine over placebo. We do know, however, that the event rate is very low at 4 months and that the absolute benefit is also low. We know that there's a level of uncertainty that's been introduced based on the large number of participants that have been lost to follow-up and those that were suspected of COVID-19 but not included in the analysis. I would say that overall we need to wait for a completed trial and published data to be able to confirm the vaccine's ability to lower the risk of COVID positive cases. We do know for sure that the vaccine effectively and reliably increases the relative risk of developing COVID-like symptoms. So you are more certain to get COVID-like symptoms with the vaccine than you are on the placebo arm or the COVID-19 arm of the trial. Vulnerable populations, what do we know? Well, the study was not designed to address outcomes in vulnerable populations, especially ones that are unhealthy, because they weren't included in the trial. Although the vaccine looks promising in the elderly patients that were included in the trial, the numbers were low, and they did not include unhealthy elderly patients. So we shouldn't we shouldn't assume that the vaccine will be effective in that population. It's also not clear how frail individuals or those with chronic conditions or diseases will tolerate the vaccine, especially because we know that the spike protein has pro-inflammatory qualities that might aggravate chronic disease overall. Its ability to prevent severe illness and alleviate the hospital burden. Well, this study wasn't designed to measure that. And available data shows that basically you've got comparable rates of severe disease and medically attended events and deaths in both arms. So again, finally, our final point, is it able to prevent the spread of COVID-19? Well, although we know that we have spike antibodies produced with the vaccine, what we don't know is whether those antibodies will help us fight a future COVID-19 infection to the point where we wouldn't be able to spread COVID-19 disease. So we cannot comment at this point, especially because it wasn't assessed properly in the trial, whether it can prevent the spread of COVID. So overall, I would say that the results looked promising in terms of reduction of COVID cases, but I'd like to see the completed trials. And until then, based on the fact that there's a good degree of disease burden, or not disease burden, but symptomology that's associated with a vaccine, that I, as a healthy adult, would probably consider not taking the vaccine. And the second thing is, in terms of its use in elderly populations, I would say that we have insufficient data to determine both the efficacy of the vaccine in that population at this time. So thanks very much for having me. Hopefully we'll have a chance to look at some more data in the next episode.
Thank you for watching this COVID Sense video. For more videos like this, please see our YouTube channel.